Good afternoon and welcome to today's webinar, COVID-19 Public and Global Health Law and Ethics in Pandemic, Human Rights and Model Public Health Laws, brought to you by the Network for Public Health Law and the American Bar Association. I'm Charles Strong, the Senior Digital Marketing Coordinator at the Network's National Office, and I'll be your host for today's webinar. A quick note that both the presentation slides and video playback for this webinar will be available on our website shortly after the conclusion of today's event. We strongly encourage attendee participation and would love to hear from you, so feel free to submit your questions at any time during this webinar by using the Q&A tab on the right-hand side of your screen. All you need to do is click on that tab, select all panelists from the drop-down menu, and send us your question. We'll be addressing them during the Q&A session towards the end of today's event. Your moderator for today's webinar are Veda Collmer and Sarah Wetter. Veda is the co-chair of the NYSBA Public Health Committee and the Chief Compliance Officer and in-house counsel at WebPT, a health IT company. Veda's practice areas focus on regulatory and compliance matters, including HIPAA, high-tech, and other healthcare IT issues, anti-kickback, fraud, and abuse, and compliance with state privacy and data security laws. Veda received the Robert Wood Johnson Foundation Public Health Law Fellowship in 2019 and completed her fellowship with the Network for Public Health Law. Our next moderator is Sarah Wetter. Sarah is a consultant with the Network's Western Region Office and a fellow with the O'Neill Institute for National and Global Health Law at Georgetown University. Sarah has previously worked with the Center for Health and Homeland Security at the University of Maryland. In this role, she consulted with state and local health departments on preparing for disasters and emergencies via law and policy. She has also worked as a research scholar with ASU's Center for Public Health Law and Policy and a staff attorney at the network. Now I'm going to pass things over to Sarah. So Sarah, over to you.
Thank you, Charles. This webinar is the first in a three-part series co-sponsored by the Network for Public Health Law, the New York State Bar Association Health Law Section, the New York City Bar Association, the University of Rochester Medical Center, Finger Lakes Geriatric Education Center, and the Collaborative for Palliative Care. The next two webinars will focus on ethical issues on the management of COVID-19 on June 25th and vulnerable populations and palliative care on July 9th. Check the network's website for more details and registration. I am now very pleased to introduce our main speaker, Professor Lawrence Gostin, who I am very fortunate to work with. Professor Gostin is University Professor, Georgetown University's highest academic rank conferred by the university president. He directs the O'Neill Institute for National and Global Health Law and is the founding O'Neill Chair in Global Health Law. He is Professor of Medicine at Georgetown University and Professor of Public Health at Johns Hopkins. Professor Gostin directs the World Health Organization's Collaborating Center on National and Global Health Law. The WHO Director General has appointed him to high-level positions, including expert panels on the international health regulations and on mental health. He has served on expert advisory committees on reforming WHO, pandemic influenza, smallpox, genomic sequencing, and migrant health. He served on two global commissions on the 2015 Ebola epidemic and was senior advisor to the UN Secretary General's post-Ebola Commission. Professor Gostin co-chairs the Lancet Commission of Global Health Law. He is the legal and global health editor of the Journal of the American Medical Association. The National Academy of Medicine, American Public Health Association, and New York Bar Association have all awarded him their Distinguished Lifetime Achievement Award. In 2016, President Obama appointed him to the President's National Cancer Advisory Board. Professor Gostin's book, Global Health Law, has been translated into multiple languages and is read throughout the world. I now turn it over to Professor Larry Gostin.
Mary Beth, all of the wonderful people that have put this program on, really delighted to be with you. I'm going to talk about public health law, like testing and tracing and isolation that we've all heard about. but also what we've seen during COVID, mass lockdowns, tracing apps on our smartphones. Then I'll shift to global health law and look at some of the global health governance institutions, including the World Health Organization. I'll then move to equity and vulnerable populations. So that's how I intend to proceed today. But before I do, I just want to take a step back and think about what we've all been through only since the beginning of the year. On December 31st, China reported the first case of a novel coronavirus to the World Health Organization. And it's really interesting for us to kind of think about this because we're now all changed. Everything about us has changed. The world has changed. We've changed. Our economies have been disrupted. Our health has been harmed in the United States and globally in ways that we've never seen. My father, who died at 102, was just a little boy during the great influenza pandemic of 1918, and I always wondered what that was like. And now here in my home, where we're all doing remote work, or many of us are anyway, I've got a 3-year-old granddaughter, and that 3-year-old granddaughter is experiencing the COVID pandemic. So many of us have said for such a long time that there's going to be a major pandemic that hits us. We don't know what the microbe will be. We don't know when it will happen, but we do know it will happen and we need to be prepared. And if anything, when we look at the COVID pandemic of 2019 and 2020, we see that so many countries around the world have not been prepared. So let's take a step back. We don't know exactly when, but we believe that sometime in December, but now it could be many months even before that, there was a zoonotic leap. There was a bat that had a novel coronavirus. The bat bit an intermediary animal, and then it came to the Wuhan wet market, where the virus jumped from an animal to a human. There was a lot of confusion and maybe lack of transparency in Wuhan and larger Hubei province at the time, and in China, about whether or not this was a serious novel virus, whether it was spread by person to person in a community type. There were lots of reports to the WHO, but this much we do know. Within a very short time after its zoonotic leap, probably at that point, it spread widely in Wuhan, Hubei province, to the mainland of China. And then it swept across East Asia, places like Vietnam, Singapore, Japan, South Korea, Taiwan. And then it moved inexorably to Europe. We saw those scenes from Italy and then really throughout the European continent. Then it's made its way to the United States, where we're now experiencing here in America well over 100,000 deaths from COVID-19. It's now on a continuing march through Latin America, which is thought to be the latest hotspot, places like Brazil, Mexico. It's moving to sub-Saharan Africa. It's been in the Middle East to Iran, Iraq, Yemen. And so we have this tiny little microbe that was inhabiting a bat's biological features harmlessly, doing no harm to the bat. And one day, through some freak of nature, this jumped to a human. And from a human, we now have a worldwide pandemic that's not only going to cause millions of deaths around the world, but also shattered our economies, created unemployment on levels not seen since the Great Depression, exposed health and racial disparities and inequities in ways that we've never seen before. It's caused social isolation, depression, mental distress. In other words, it's completely changed our lives, all of our lives, every person on the planet, and it's changed the world. And, although we like to come back and just think, oh, what an unfortunate event it was, there's two things from a biological perspective that we need to step back and think about. One is that this wasn't unexpected. We knew it would happen. We just didn't know when and which virus it would be. And secondly, you have to just bow down and be humble in the face of Mother Nature that was able to spur a microscopic organism that we couldn't see that swept the world and changed the world in only a matter of a few months. That is truly awesome. And so the question for us today is, what are we going to do about it? How are we going to respond to COVID going forward? Or will we just be blaming each other retrospectively and in real time? Will it unite us or will it pull us apart? And will it create a global community with global norms and the rule of law? Or will we revert to populism, nationalism, fierce sovereignty, self-interest, my country first? In other words, will we be selfish, either as individuals or as nations? Or will we see that we're all in this together and that we need to do something and do it fundamentally? So thanks to the Network for Public Health Law and the American Bar Association for putting this on. Little in this side of this equation. From a public health law point of view, this is in one way quite expected and in one way quite unusual. It's quite expected because, after the anthrax attacks of 9/11, the CDC asked me to lead a team to draft the Model State Emergency Health Powers Act. Later on, with help from the Robert Wood Johnson Foundation, we worked on another model law called the Model Turning Point Act. And many states have adopted one or both of these in some form. And what they do is they look at some of the things that used to be just, public health wonk stuff, but now is a common lexicon. They were rules of law based upon science and evidence and human rights to say whether and when you can test somebody for a disease, screen populations for the disease, trace their contacts, isolate people who are infected, quarantine people who have been exposed or not yet symptomatic. So all of that, is governed, and it's governed fairly well. But we've seen something, quite new with this pandemic. I remember early on coming back to the city of Wuhan back in December. And at that time, I happened to have a prominent journalist in my home. He'd been locked out of his house. He came, and I was giving him some tea and biscuits with my wife, Jean. And I said to him, I've just heard from my friends in Wuhan that there's this novel virus, and I think it could be a really serious problem. And this national journalist just said, pass the cookies. He could have had a Pulitzer Prize, but he never went with it. And so no, they didn't expect it. But there's another thing we never expected, which is when we got into kind of by mid-January, Xi Jinping and China ordered a major lockdown of Wuhan and wider Hubei province, affecting about 60 million people. And that lockdown then began to expand through mainland China. At the time, I said, the world has never seen this kind of a massive lockdown of this scale, not even in 1918 during the great influenza pandemic. And then I said, quite foolishly, in retrospect, this could only happen in China. You could not lock down, and I even used this exact language, you couldn't lock down New York, London, or other major metropolises in liberal democracies. The rule of law wouldn't allow it, would just never occur. But of course, that's exactly what did occur. It happened in Milan and then all over Italy. It happened in London and all over the UK. It happened in New York, all over the United States. And indeed, it even surpassed China when India locked down over 1 billion people. So public health laws never accounted for any of that. They never thought that you would actually just massively take away people's liberty. They never thought that people wouldn't have the right to have religious services because it would be transmitting a novel disease. Never thought that you could force businesses closed. And so public health law was really inadequate to the task. And there was really very little we could do about it because this was happening in real time. It was an emergency like nothing we've ever seen. And so we, by and large, respected it. Certainly, there were protests against the lockdown. The president and his supporters wanted to get people back to work when public health people were saying no. But public health laws didn't really account for this. And so I think we're going to need to amend those public health laws. I'm working with groups to do that, including the Uniform Law Commission. So although we have some really good laws, we need to take this into account because when this is over, I really hope that the next time we have an outbreak, we're not going to jump to the kinds of draconian measures that we've seen here. And of course, now we are opening up in the United States, but all around the world. We're likely to see a resurgence of cases. And there's also likely to be new problems for us. How are we going to deal with the autumn? when people are going back to work, they're coming back from vacations, they're going back to school, they're traveling back to their universities. And in the middle of the autumn, there's going to be influenza season. And so we're going to have two co-circulating epidemics of COVID-19 and seasonal influenza. It's really jaw-dropping about the challenges that we have faced and that we're about to face. So we haven't seen anything like it. There's another thing that is new and novel that's causing some interesting debate. I had a recent article in the Journal of the American Medical Association on this issue. One of the things that China did in addition to its lockdown is it developed smartphone technology, an app on your smartphone. In China, everybody had to download it, had to use it. And what it did was it tracked all of your movements, so it was a location app. But it also allowed 2 smartphones or 5 or 10 or 100 smartphones, when they come close to each other, to chirp at one another. And so you know who the contacts have been. And by looking at symptoms and who you've been in contact with, the Chinese put on your phone whether you're green, that is all clear to travel, yellow, restrictions, or red, you can't move. Now that was really draconian, but other countries have used it in less draconian ways, but still location apps. And they've used it very successfully. Places like Taiwan, South Korea, really brought the epidemic under control that way. Germany, UK's thinking about it. Germany did it. Israel had a very successful rollout of their smart app technology. In the United States, there are great privacy concerns, and so too in Europe. And so there's an enormous debate about, whether or not we should use these location apps, and who would have access to the data. Would private companies harvest the data? Would it be used for secondary uses like police, immigration, law enforcement, overall surveillance, intelligence purposes? So Google and Apple are both developing these apps, but in a much different way. And most importantly, if it were rolled out in the United States, and I think it will be in just not the whole country, but there will be some uses of it, that it would be voluntary, that people would not be forced to use these apps. But of course, there's a trade-off. The less people that use the apps, the less likely it is to be effective from a tracing point of view. And so here's an example of pitting, the right against what otherwise could be an effective aid in tracing contacts and isolating those who are infected, quarantining those who have been exposed. So there have been, I would say, dozens, if not hundreds, of national experiments in how to handle COVID. Some countries have done extraordinarily well. I've mentioned places like Taiwan and South Korea, Israel. Germany's done fairly well also. Australia, New Zealand have been extraordinarily successful, almost eliminating COVID-19 from their shores, although they are island nations, so it's easier for them to do that. But then there are other countries that have seemed to have hardly known where to begin. I was just on another webinar for the American Society of International Law. And on that webinar, we were kind of thinking about how countries have responded. And of course, the United States comes prominently to mind. Beth Cameron, who was the White House National Security Council chief on global health for Obama, mentioned that the United States scored highest in preparedness for a pandemic under the Global Health Security Index, which I worked with a bunch of partners. But it turned out that even though the United States ranked the highest, its leadership never unleashed that capacity. And as a result, we've handled it very badly. Other populist leaders have handled it badly too. Brazil comes to mind, Bolsonaro, Putin in Russia have handled it badly. And so what lessons can we learn? What are the best national approaches we need to do some rapid lesson learning about what the most effective response is? It may be, as the Prime Minister of New Zealand said, act early and act hard. And that probably is the best lesson. So I've had a kind of a whirlwind tour of the national level. Now let's pivot to the global level. Global governance for health is enormously complex, and there's no possible way that I can cover all of it. As Sarah said, I've written a book for Harvard University Press on global health law. It's well over 300 pages, and I can't possibly begin to fashion a summary of that here. But I think I want to focus on, three areas. One is the governing instrument for global health security, which is the International Health Regulations. It's one of two major treaties negotiated by the World Health Organization. The second is called the Pandemic Influenza Preparedness Framework. It's another WHO international instrument, but it's not a binding treaty. And then finally, looking at WHO itself, which has been embroiled in enormous controversy over this COVID pandemic, even though I think they've performed overall quite well. Not flawlessly, but quite well. So the international health regulations were revised substantially after another major coronavirus, SARS-1, which began also in China, then moved to Canada and Asia. SARS taught us a lot of lessons, and one of them was the inadequacy of the international health regulations. And so they were fundamentally reformed in 2005. And, they've performed fairly well, but not, again, far from perfect in relation to, other events like MERS, another coronavirus, or Ebola virus disease, or Zika, for example. But they've never had a stress test the way they have with this pandemic. And, one of the many charges against China and the WHO is that the international health regulations were not abided by and that China wasn't fully transparent. Now, whether that's true or not, and I'll get to that in a moment, there are many things that we found that we need to kind of think through in terms of reform of the international health regulations. One of them is that WHO currently has no power to enforce it. And so if it felt that the data coming out of China was not fully accurate, it had no means to independently verify those data. There's also been a lot of controversy about declaring a public health emergency of international concern. This is true not only with COVID, but also Ebola and other diseases. where there's been inconsistency in the response. The IHR also requires all countries to have core health system capacities to rapidly detect and respond, but yet most countries don't. So there's a lot of reform that we need to do. And the World Health Assembly recently passed the most important resolution, which was that there was going to be an after action report. It's unclear when that's going to take place. That's going to look at the lessons learned at the governmental level, but also at the IHR level and the international health regulations, and WHO itself. The other international instrument that WHO has brokered is the Pandemic Influenza Preparedness Framework. It's called the PIP framework. After Ebola, there were several commissions in the UN Security Council, UN Secretary General Commission, which I advised on, National Academy of Sciences. I was a member of that commission and others. And they recommended that the PIP framework be extended beyond influenza to cover other microbes like coronaviruses. And that would have been very helpful here, because what it does, it requires equitable sharing of biological samples and genomic sequencing data. But it also has a framework for equitable sharing of the benefits of novel treatments like antiretroviral or vaccines. And I'm going to come to vaccines as a special part of this talk. So there's a lot of reform that we need to think about from the PIP framework and the international health regulations. But both of these instruments are governed by the World Health Organization. And I think it's no secret to say that WHO has been caught in the middle of a geopolitical struggle between the two world superpowers, both with highly nationalists, strong populist leaders, Xi Jinping and Donald Trump. And we've seen this kind of blaming the other and then blaming WHO in the middle. And I do think, there were, if I were WHO, I would have done things differently at the very earliest moments when China was reporting probably inaccurate data to them. But they were powerless to do very much about it. And I think WHO has performed very well. They've been highly transparent, but they're under a microscope. We could see that with controversy over its recommendations regarding universal mask use, and most recently, asymptomatic transmission of SARS-2 virus. So these are kind of really important things. I often have said, and I've written a lot about WHO in relation to COVID, that the world has the WHO it deserves. Because it doesn't support WHO politically, doesn't give it sustainable funding, powers to ensure compliance. In other words, they've left WHO toothless and without adequate funding and politically blowing in the wind. But I hope that out of this unprecedented crisis will come an opportunity. And if I had my wish list about what that opportunity would be, it'd be twofold. At the country level, it would be universal health coverage, so that every country in the world guaranteed the right to health to every single resident in that country. That's so important. As Dr. Tedros from WHO has said, all roads lead to universal health coverage. But I also think this is an historic opportunity to change the World Health Organization for the better. That is, strengthen it, fund it, politically support it, give it the power and the prestige that it needs, give it the independence and scientific integrity without interference, We desperately need a strong World Health Organization. And, if you think back to 1948 and when WHO became the first specialized agency of the United Nations, the World War II precipitated an event that was unthinkable. We formed the United Nations. We adopted the Universal Declaration of Human Rights. We passed the WHO Constitution. And so out of a crisis can come an opportunity, and I hope that we choose opportunity in the face of this crisis. One of the issues that COVID has really brought to light is the problem of equity. It's a huge problem. You would think that if there was anything that would affect everyone equally and that would be blind to color or poverty, it would be a virus. Viruses should be affecting all of us in the same way. And yet, COVID-19 certainly hasn't. And I've said this about many diseases. If you think about tuberculosis, it used to be called the social leveler, but it went to the poorest racial minorities, to poor countries, and to poor people in rich countries. AIDS started in the predominantly, reasonably affluent white, among white gay men in high-income countries, but it soon became a disease of poverty, of race, of place. And the same thing has happened with COVID. We've seen in the United States and in other places huge racial disparities in how COVID has affected people and their lives. We've seen huge racial disparities in how it's affected unemployment and economic prosperity and the ability to meet ends meet. So these things have really exposed a dark underbelly of our society. Martin Luther King, I think, said it well. He said, all inequities are unjust, but of all the inequities in the world, health inequalities are the most unconscionable. And I think that's true. And one of the kind of social upheavals that has occurred since we've begun this pandemic has been the death of African Americans based upon police violence, a great racial injustice that's been ongoing and historic. And so with that, we've seen protests, and it's not just in the United States, it's around the world. But I think these protests are not just about police violence, but of course they're about that. But they're also about wider racial injustices, wider economic injustices, wider health injustices. And I don't think it's a coincidence that these kind of global protests have emerged. I think that the reason is because of COVID and what COVID has demonstrated to us. Police violence was the spark, but the tinder was always there. And we've seen problems of ethics arise frequently. So in order to deal with COVID, we need reliable and ample testing and contact tracing. We also need a personal protective equipment for our frontline workers, ventilators for people who are ill. But what we've seen, rather than sharing And rather than all of the importance of equitable distribution of these resources, we've seen it go to the highest bidder. And we've seen a free-for-all for these scarce resources. And that's not the way it should be. But when we're thinking about triage in hospital beds, ventilators, ICU beds, when we think about personal protective equipment testing, that's actually small potatoes compared to what we're about to see. Because right now, there's an unprecedented race for a vaccine. In all of my lifetime, I've never seen a commodity, a health commodity that seems so vital to return to some kind of normalcy globally than having a COVID-19 vaccine. The World Health Organization recently reported that 130 vaccine candidates. 3 of them have already completed phase 1 clinical trials, 1 in the US, 1 in China, and 1 in the UK. But there's also vaccine development in India, Germany, and Russia, among many, many others. And unfortunately, the race for the vaccine is almost like a moonshot, and maybe even more so because it's projecting power between the world superpowers of who can be the first. And so I worry, and I worry a lot, if and when we get a COVID-19 vaccine, at least at the beginning, and maybe for a long time, we're going to be in a position of scarcity. Will countries like China or the United States hoard vaccines? Will they serve their populations first and foremost over others? Or will there be a more communal sharing with our fellow global citizens in the Americas, in Africa, in the Middle East, in the Indian subcontinent? These are really consequential questions. They go to human rights, they go to ethics, they go to downright ethics and justice. And it will expose what we are as a humanity, whether we are whether we're a people who care about other people, or whether we're selfish, individually selfish, or nationally selfish. And I hope we choose the role of the common public good and sharing of this commodity when we get it. I'm going to end by just talking about vulnerable populations, because in addition to the racial disparities, we've seen the most marginalized, the most vulnerable in our societies suffering most. We certainly saw it in nursing homes all around the world. Nursing homes have been hotbeds for disease amplification of COVID-19. Immigration communities where you have people that are congregated together. They can't do social distancing because they're too close together and they're congested. They can't do personal hygiene because there isn't enough clean water and soap. They don't get the health care that they need. We've seen it in prisons, and we've seen it in homeless shelters, where people are in crowded conditions, vulnerable, have multiple pre-existing conditions. And this is where the vast amplification of the COVID-19 epidemic has occurred among the most vulnerable, the old, people with pre-existing conditions like heart disease, diabetes, respiratory ailments. We've seen it in American Indian populations and other native groups. And so we have to really pay attention and give particular attention, not just to public health, but for the public health of those who are most acutely affected. We know who they are, and the policies that we choose and the protection that we afford these very vulnerable populations will be a measure of our humanity and our civilization. I started this session by looking at the awesome power of nature, about how a tiny microbe could jump from a bat to another animal and to us, and how in so many ways nature is always a step ahead of us. Think about all of the miraculous achievements science has made in relation to antibiotics and antimicrobials, but yet nature adapts and genetically adapts, and bacteria, viruses, and others become immune to our treatments. And so we could someday find ourselves in a world where we don't have effective antibiotics or antivirals anymore. Vaccines, can be effective, but only sometimes marginally, like with influenza, which only has, anywhere from 40 to 60% effectiveness rates, depending upon how well the vaccine matches circulating virus. So there's so many things to admire about Mother Nature, but as we are admiring it, we have to be smart about it. We have to realize that, COVID-19 isn't going away. These threats aren't going away. We're going to see more novel infections jump from animals to humans. We're going to see more human-to-human spread. We're going to see the world's greatest killer emerge even more strongly with climate change. And I have in mind mosquitoes. Kills more people than even humans do. We're second, humans are second. So there's so much we can admire, but we also have to be humble and we have to prepare. And so if there were one lesson, actually I'm going to give you two lessons that I hope we will learn from COVID-19. One is to respect the awesome power of biology and nature and to prepare for it, to invest in vaccines and treatments, to invest in strong health systems, to invest in outbreak preparedness and rapid response. And that those kinds of investments will pay dividends. But the other thing that I hope will come out of this is that we will see ourselves more as a global community and not as individuals with our rugged individualism and thinking about what my rights are. I hope in future we're going to start to think it's not about me, it's not about my country, it's about all of us. It's what obligations me as a human being owe to my fellow human beings in my community, in my world. It's what my country owes not only to its citizens, but to citizens of the world. We are indeed in this together. If we don't see that in the face of climate change, of biology, of pandemics, we will never see it. And so let's turn this unprecedented crisis into an historic opportunity, just the way we did after World War II with the United Nations and the formation of the human rights framework and the formation of the World Health Organization. It's up to us to get the world we deserve. And so let's work for it. So again, thank you all very much for bearing with me. I know it was a very long talk, and I'm very happy to stop and have a conversation, take questions, whatever is most helpful.
Thank you, Professor Gostin, for this very inspiring and informative presentation. It certainly is an opportunity for us to make some changes, especially to address some of the lingering issues that occurred prior to the pandemic that you talked about in your presentation that became more relevant. One of those that you had talked about was the reform of the adoption of model laws, such as the emergency preparedness laws and crisis standards of care. What do you see as barriers for some states in adoption of these laws, and what recommendations do you have for the future, for future adoption of these model laws?
Well, I think that we do want to have more evidence-based legal reform. I would certainly like to see states adopt laws that have a genuine balance between human rights and public health. I think we can do that. I think the model laws that I helped draft are still quite apt, but we're going to need to reform even those to deal with things like, massive lockdowns, tracing apps and things like that. So we all have a lot of work to do, and the ABA and the Network for Public Health Law are both well suited to help us lead those kinds of activities, and I hope that we will.
Thank you. Another question from our attendees along the same lines is that health equity or lack thereof has certainly been exposed by COVID-19, yet competing healthcare delivery debates continue to stymie the dialogue. What action steps do you foresee that break the stalemate and bring healthcare justice?
Yeah, and I assume that's addressed to the United States. There have been a lot of proposals for reform, but it's all over the map. The GOP would like to see much more of a market-based approach. It's been critical of the Affordable Care Act. There are others who say that what we really need is to expand the Affordable Care Act, and then still others that want some form of universal health coverage. The common phrase is Medicare for all, but there are many pathways to universal coverage. Medicare for all is just one of them. It's hard to see how the United States will come together on this. It's hard to see right now the United States coming together on anything very important. And if there were this was a different session, in my view, I think our democracy is broken in many ways. Things that I worry about that really affect our ability to come together as a nation and do things that are really substantial, big, and important. I'll give you what I think would be the common ground. I've lived in universal health coverage countries around the world. I've lived in the UK under the National Health Service. I've lived in Canada under its single-payer system. I've lived in Australia with its form of Medicare. And I can tell you this, and I've spent a lot of time in Germany and Japan, other countries. Universal health coverage in all of those places, they're different forms, but they're all guaranteeing health care to everyone, is by far better than anything we have in the United States. And so if you asked me, would a Medicare for all or other similar universal plan be better for the United States? I would say yes, of course. Undoubtedly, it's better care, better outcomes in other countries. But having said that, I can't see that happening in the United States. Not in the foreseeable future, and probably not in my lifetime. There's just too much invested interest from health insurance industry, too much political division, pharmaceutical industry. It's a really complicated thing. So this is what I would do. It would just be a very, very simple 3-part plan, which I think everybody could come together on. And I've suggested this to the Biden campaign. I hope that somebody's listening. The first thing I would do is I would close the loopholes and expand where I can the Affordable Care Act. It's a solid basis. It's the law of the land. It's generally popular in the United States. I would make sure that we have no donut hole, that our subsidies are for the uninsured are robust, and so generally to really solidify the Affordable Care Act. That's step one. Step two is I would vastly expand Medicaid. Now, due to, I think, a very bad decision of the Supreme Court, a lot of red states have refused to expand Medicaid. But I think even with the Supreme Court that we've got, the federal government could make it so financially attractive to states to expand Medicaid, that more would do it, and maybe everyone would do it eventually. So part two is Medicaid expansion. And part three is an idea that I think is a political no-brainer, would have very little cost and enormous upside. It's what I'm not calling it Medicare for all. I'm not calling it Medicare for 55-year-olds and over. I'm calling it Medicare for children. So the United States guarantees health care the same as an elderly person would have for anybody from 0 to 18 years old. Imagine that. Imagine what it would do to learning and education, to dental care, to mental health, to physical development. Imagine what it would do for the well-being of families and communities, to ensure that every child, and nobody would be politically against it, at least they shouldn't, because everybody wants health care for kids. But more than that, it would cost very little. Medicare costs a ton because it's old, sick people. Kids are generally healthy. So we could do this at very, very little cost. And so that 3-part plan, which is basically the Affordable Care Act strengthening, Medicaid expansion, and Medicare for children. With those three, I think we'd have a politically sellable package. It would be economically affordable, and it would be assure as close to universal coverage as we can possibly get. And I've left out one group, but I wouldn't. I would cover every inhabitant of the United States, whether or not they were a lawful resident or not, including unlawful immigrants. I know that that's not very popular, but I would do it, and I have very good reasons why I would.
Thank you. Another question from our attendees. Can we foresee national leadership from the CDC or other agencies in the U.S. or continued chaos of state experiments?
Well, I don't think it's a secret that, the leadership of COVID at the national level has been, quite weak. It's had its strengths. The coronavirus task force in the White House, Tony Fauci and others, are national treasures, and Tony is. I've known him for many decades. But we can see that our scientific agencies and our scientific professionals and our medical professionals have been sidelined, criticized, marginalized, and no more so than the U.S. Centers for Disease Control and Prevention. CDC should be the shining star of our federal agencies. They're amazing women and men dedicating their lives in a professional way. They're beyond doubt the best in the world. But yet they performed not well, not wholly well during COVID for many reasons. But I think first and foremost is the fact that they've been undermined. When they put out guidance, the White House often retracts it or sends it back. They're always looking over their shoulder at their political masters. They're demoralized. They have far too little funding. And under any populist regimes, we're always going to be seeing an attack on science, and it's very, very sad. We've seen the WHO criticized for things like masks or asymptomatic transmission. We've seen CDC criticized for its guidelines on religious services or for its testing policies early on in the pandemic. I hope that one of the opportunities that will come out of COVID in the United States is strengthening the CDC, but also reasserting the prominence and importance of science and scientific integrity and objectivity in our daily lives, and particularly in the health and safety aspects of our lives.
Thank you. Now I have a question from an attendee on vaccines. There is a well-established body of law that supports exercise of state police power in mandating vaccines. What are your thoughts on such an approach for the COVID-19 vaccine? Should the safety and efficacy be established and a vaccine approved?
Well, I've been thinking a lot about the confluence of flu and COVID, and particularly in relation to vaccines, both for seasonal flu and COVID. The bottom line is this, that our existing vaccines, and I hope with regulatory oversight, a COVID-19 vaccine will be safe and effective. I hope we don't cut corners so that we can actually establish the safety and efficacy of a COVID vaccine. The goal, clearly, for both flu and COVID is to gain as near universal coverage as we can. I think there are a lot of ways to do that short of a mandate. So far in the United States, we've only had mandates for school attendance. We don't have any adult vaccine mandates in the United States. Would be required if we were to go that route for flu and COVID, because it would affect adults as much, if not more, than children. I think there's a lot of things we could do. We can incentivize ample supplies of vaccines. We can have a health communication campaign that really explains the importance of being vaccinated. And then hopefully we're going to get sufficient herd immunity that way. If we can't, I'm not opposed to the use of a mandate, but I would see a mandate as the last resort, because it just feeds into the anti-vaccine a narrative, it raises political alarm bells. And so if we can do it without a mandate, I'd prefer it. But ultimately, as the Supreme Court said in Jacobson versus Massachusetts, you can require even adults, competent adults, to be vaccinated against a dangerous infectious disease.
Thank you. And then along that line, do you believe that a more expansive public health education could help change attitudes about vaccination?
Well, I hope so. Right now, there's a lot of anti-vaccine sentiment, particularly in social media. We've seen with COVID-19 a couple of things happening. One is that the rate of childhood vaccination coverage has plummeted, and that's a concern. And the schools closed and universities closed, businesses closed. We're likely to see continuing low levels of childhood vaccination. So that really worries me. With influenza coming, I want to have a very large coverage for seasonal influenza vaccine. And for COVID-19, if we do get a vaccine, we're going to need to really do a big education job, because at the moment, polls suggest that quite an alarmingly high number of Americans would not get the coronavirus vaccine if it were currently available. And that's a big worry. So we've got our work cut out for us, and we have to start thinking and planning right now.
Thank you. Then along that same line, what decisions do you think would be made about who gets the vaccine, and what do you recommend in terms of helping to build public trust?
Well, those are two different things. I mean, public trust is built by sound communication. You have to show the public, you have to be honest with the public, tell them everything you know in clear, simple language, what you don't know and what you're doing to find out what you don't know. So I think health communication is very, very important. We know how to do it, but very often we don't do it very well, and we don't invest in it at all. But the next question is, what do you do if you have vaccine scarcity? I've talked about, there are two different things. How do we allocate a scarce vaccine in the United States, and how do we allocate it globally? In the United States and in any given country, I would think that the first users of the vaccine and the first priority would be essential workers, would be health workers, firefighters, police, and other essential workers that we need to keep our health system and our economy running. After that, we need to make some ethical choices. Obviously, most high-risk populations should get it: prisoners, nursing homes, immigrants, others, and targeted populations, inner cities, Native American reservations, and things like that. And then we would just have to go out and have a transparent, highly deliberative, accountable process of how we allocate these life-saving vaccines.
Thank you. So changing directions, one of our attendees asked this question: one of the challenges in global health is the rise of chronic, I'm sorry, I lost that. Chronic non-communicable diseases which don't capture the attention of policymakers the way that dramatic events like the pandemics do. What legal strategies are there to address chronic disease?
Well, there's no doubt that over the long term, non-communicable diseases are going to be much more consequential to our health. Things like cancer, diabetes, cardiovascular disease, respiratory disease. One of the interesting things is we've seen the intersection of infectious diseases, COVID-19, with non-communicable diseases, because people with chronic diseases have much greater vulnerability and are at much greater risk. But even beyond that, we do need to focus on things like nutritious diet, physical activity. We need to, and tobacco, alcohol use. We know what the upstream risk factors are for non-communicable diseases, and we know we have really good legal and non-legal strategies for reducing smoking, alcohol use, and for encouraging healthier diets and physical activity. But we don't emphasize those, but we must and we should.
And then can you address the erosion of public health communication, especially during the pandemic, through a lack of federal response, the abject failure of the CDC, and most recently, zero World Health Organization COVID briefings? And then what, combining another question, what do you recommend as a source of truth for reliable public health communication?
Right. Well, first of all, the question had the assumption that WHO and CDC have been abject failures in this. I don't accept that. I think they've done, overall fairly well under very, very difficult circumstances. And I can talk a little bit about the asymptomatic brouhaha with WHO or masks or things like that. But if you were to ask me the problem with health communication, it would be twofold. One, it would be that public health agencies themselves are focusing so much on science that they're not thinking carefully enough about health communication. I'm, working with the World Health Organization now, trying to help in terms of health communication. It's an amazing organization, and to kind of convey the science well. So the first thing is that public health experts, WHO, CDC, others, need to be able to explain the science more. And not just the science, but the scientific uncertainty, because science is evolving. It's never going to be static, and it's never going to be certain. But the second thing is we need to get, politics out of science. Politics can be good if it's supportive and it's reinforcing science, as in many places around the world. But when our leaders are undermining or muzzling or impeding scientific advice, it's not a good thing. I've given one example. At one point, the Vice President Pence said in relation to COVID that all the public health agencies should be clearing their messages with the White House. And I would say it's exactly the opposite, that the White House should be clearing its messages with public health agencies. So I think two things, yes, public health agencies have a responsibility to do better in explaining the science, number one. And number two, they need to get political obstruction, political impediments, or undercutting their messages away, and so to give science more independence, more integrity.
Thank you. So you have talked during your presentation about the impact that COVID-19 pandemic has had on vulnerable populations, particularly around the homeless populations. One of our attendees submitted a question about this person's observation that there were overly aggressive policing policies and incarceration of homeless and immigrants. And so what are your recommendations for implementing policies that will ethically and legally continue to protect these populations, or even do a better job in the face of the next pandemic to protect vulnerable populations?
The protecting vulnerable populations is probably not just a simple law. We need to have a societal commitment to it. And very often, the vulnerable populations are the asylum populations, the politically weakest, and they get the least political support. I'm thinking about immigrants, migrants. I'm thinking about prisoners. I'm thinking about elderly, often senile populations in nursing homes. I'm thinking about inner city African Americans. I'm thinking about American Indians on their reservations. All of these things require special attention. I've often thought that the best definition of equity is trying to fairly distribute, protection and public goods to the population at large, but with particular attention to the people who are most marginalized and most vulnerable, because they're the ones that have the least loud voice, the softest voice, the voice that's unheard, and not just unheard, often actively discriminated against. I think we can see that. We see that on our streets now with race, but it's equally true on so many other levels. In prisons, immigrants, we tend to blame them, castigate them, and we think of them as the other, rather than thinking about them as part of our community, equally deserving of protection.
Thank you. Shifting gears to a privacy issue, you had talked about the contact tracing applications being used in China and elsewhere. Can you talk about how the impact of HIPAA and other privacy laws that these types of software tools would have if being used in the U.S.?
Yeah, I don't think HIPAA really has much to say about that. I mentioned a JAMA article that I had on these tracing apps, and we concluded that legal privacy protection in the United States really doesn't cover that, and these aren't really protected data under the under HIPAA. So we would need to legislate and regulate these apps in very specific ways to make sure that they were not violative of privacy and they didn't stigmatize.
Thank you. And then shifting gears, what laws apply to foreign nationals coming from hot zones abroad who may or may not be infected or carriers?
Sorry, can you repeat that?
What laws apply to foreign nationals coming from hot zones abroad who may or may not be infected or carriers?
I don't know what exactly you mean, whether you mean do they mean travel restrictions?
Yes, I think I'm interpreting that to be travel restrictions from individuals coming from outside the U.S. into the U.S. from areas that are highly infected.
Right now, the United States is the world's epicenter, so to try to protect us from other places seems almost laughable by this time. But travel is a very complicated thing. Eventually, the world is going to get back to traveling, and so our best response isn't to kind of wall off the world, but to have a uniform policy of testing, tracing, isolation, quarantine. I think when people come from hot zones abroad, we could have a period of, say, self-isolation for 14 days. That's what the UK has done. It seems, at least at this point, to be a sensible precaution.
Thank you. I think we have time for a few more questions, if that's fine with you.
I think maybe I've been trying to send a message. I was, it's going on for very long. My advice is to perhaps to try to wrap it up now, unless there are really
okay.
important questions. I think any span in an hour and 20 minutes is probably as much as anybody can take.
Okay, that's fine. So I think we can wrap it up. You have touched on some of the most important questions, so we really do appreciate your time today. And I will pass it over to Charles at this point.
Okay, thanks very much, Veda. I appreciate it. And thank you to everyone. It's been a terrific session. Great questions.
Yeah, absolutely. Thank you, Veda, and thank you again, Professor Gostin, for presenting today. Just a few final notes to all of our attendees. All attendees will be receiving an email from the network with the video playback of this webinar, as well as a link to our brief webinar survey. And the survey takes just 1 minute to fill out and provides us with some great insights, especially in regards to what topics you might be interested in for future webinars. Join us on June 25th for the second installment of this webinar series, where speakers will address ethical issues that have arisen in the context of scarce resources during the COVID-19 pandemic and the challenges presented by the absence of uniform statewide ethics guidelines. Learn more about that webinar and view the network's collection of resources on the pandemic at networkforphl.org/COVID-19. So that concludes today's webinar. Thank you all for attending and have a great rest of your day.
Thanks very much. Take care.